have no disclosures. And so in terms of, just to put into context what we're going to cover this morning in the next 50 minutes, this is a really broad variety of topics. We're going to go from fetal circulation all the way to the sarcomere and vascular physiology. It comprises about 7% of your exam. As I mentioned, we're going to touch on normal fetal circulation as well as in the context of specific congenital heart defects, the transitional circulation, and then spend the bulk of our time talking about the basics of cardiac structure and function, some of the features of ventricular function and determinants of cardiac output, and then finish with a nice review of both the systemic and pulmonary vascular bed. All right, can everyone hear me? All right. So starting with fetal circulation. So a few key points. The lungs in fetal life are obviously fluid-filled and not participating in gas exchange. So gas exchange is occurring at the placenta. And the RV and LV are functioning in parallel, not in series in the fetus. So when we talk about the fetus, we talk about cardiac output in terms of combined ventricular output. The RV and LV have very different jobs because of the unique intracardiac shunts and also the function of streaming. The RV functions to pump mostly deoxygenated blood across the PDA back to the placenta, while the LV functions to pump more highly oxygenated blood to the coronary and cerebral circulations. The umbilical vein, as you know, carries the most highly saturated blood in the fetus. About 40% of the UVC blood is delivered to the left hepatic veins in the portal system, but most of the UVC blood is going to bypass the liver, about 60%, via the ductus venosus. And this highly saturated blood is then going to be preferentially directed by the eustachian valve and the crista dividends across the PFO. Blood crossing the PFO combines with the blood returning from the pulmonary veins, and the net effect is delivery of highly saturated blood to the coronary and cerebral circulations. Blood returning to the fetal heart from the SVC is highly deoxygenated, and almost all of this flow is directed across the tricuspid valve to the RV and along with the coronary sinus flow and the remaining flow from the IVC. And the majority of this flow will traverse the PDA to the descending aorta and back to the placenta. In considering the distribution of blood flow in the human fetus, again, we think of combined ventricular output. Fetal circulation is RV dominant in terms of total workload. From the RV, almost 2/3 of the flow bypasses the lungs. And from the LV, the majority of cardiac output goes to the head and neck. Important to point out that under normal fetal circulation, the area of the aortic isthmus receives a very small amount of combined total output, only about 9%. And under normal conditions, there's no retrograde flow from the ductus to this region of the circulation. So you can see this is a really vulnerable area of circulation, and even small changes in blood flow across the isthmus can result in abnormal development, as we see clinically in the development of coarctation. A quick reminder that we often reference data from fetal lambs when discussing our understanding of fetal circulation, specifically all of the landmark work from Dr. Rudolph. In his most recent text, he did reference data specific to human fetuses based on echocardiography studies. There are some differences to know about, specifically a larger proportion of cardiac output devoted to the brain and actually to the lungs based on these human fetal echo studies. But I think for the purposes of the test, really to focus on the classic data from fetal lambs, which is the bulk of our understanding. Also important to note that over the course of gestation, how fetal cardiac output changes. Notably, as the fetus is preparing for postnatal life, there is a notable increase in cardiac output being directed to the brain, to the lungs, and the GI tract. And later in gestation, a decrease in the percent of flow directed to the placenta. Finally, important to be aware of some of the ways in which the fetal and neonatal myocardium really differs from a more mature heart. Both the fetal and the neonatal myocardium really have limited ability to increase stroke volume and contractility. They're typically functioning right at the peak of their ventricular function curves, and very minimal, if any, change in stroke volume can be achieved by increasing preload. In addition, these hearts are very exquisitely sensitive to afterload, and really changes in heart rate, both increases and decreases in heart rate, are the primary way in which the fetal and neonatal myocardium can augment stroke volume. All right, so now let's discuss the important changes that occur immediately after birth and in the first few hours of life. The biggest change that we'll discuss a couple of times is the transition from the placenta to the lungs for gas exchange, resulting in an abrupt decrease in PVR and a 3 to 8-fold increase in both pulmonary blood flow and overall cardiac output. This is mediated by both mechanical expansion of the lungs as well as increased oxygen content of the blood that's going to cause pulmonary vascular dilation. As we know clinically, there is an initial dramatic decrease in PVR, but PVR continues to decline over the first 6 to 8 weeks of life. This is often when we see the clinical signs of ventricular level left-right shunts, and this occurs as the pulmonary vascular bed continues to remodel. In addition to the decrease in PVR, there's an abrupt and dramatic increase in SVR as the low-resistance placenta is removed from the circulation. The combination of the changes in PVR and SVR has additional side effects. So there's reversal of flow in the PDA, which normally becomes predominantly left to right. And with the increase in pulmonary blood flow and increase of flow of blood to the left atrium, reversal of flow in the ductus, there's increased left atrial pressure, which is going to result in mechanical closure of the foramen. So this transition is a huge physiologic challenge for the neonate. There are increased metabolic demands due to the baby needing to maintain her own temperature and take over the work of breathing. There is a compensatory increase in total cardiac output, with the greatest increase in demands on the left ventricle. And these changes in loading conditions and increase in flow from the LA are all going to serve to increase the afterload on the left ventricle and result in physiologic hypertrophic remodeling of the LV. So this is just a quick summary of some of the important comparisons between fetal and neonatal life, many of which we've discussed already, really with postnatal life being marked by marked increase in metabolic demands and cardiac output, and an environment that is much more stressful than the antenatal environment. All right, so now we're going to go through a review of some of the key congenital heart defects in the context of their effect on fetal circulation. We'll start with hypoplastic left heart syndrome, mitral, and aortic atresia. So in this circulation, the RV maintains the total cardiac output. There's complete mixing of blood from the SVC and the IVC. And in this scenario, the flow across the PFO is reversed, left to right. Important to note that all of the flow to the coronary circulation and across the arch is retrograde. And importantly, that the saturation of blood delivered to the cerebral and coronary circulations is significantly lower than under normal conditions. Less severe but still on the spectrum of left-sided obstruction is aortic stenosis. So the impedance to LV outflow and increased afterload can impair LV stroke volume, and subsequently, depending on the degree of obstruction to LV outflow, the increase in pressure in the LV can lead to increased left atrial pressure and can impair flow from right to left across the patent foramen and impact left heart growth. Typically in this circulation, saturations and combined ventricular output are preserved, but under conditions where there's significant impairment to LV outflow, you can have retrograde flow across the ductus arteriosus. Looking at the physiology of a VSD in utero, because under normal conditions the RV and the LV are under generally equal pressure, shunting across a VSD in utero will depend on the size and the location of the VSD and to what extent it impedes flow. So a posterior malaligned VSD that creates crowding in the left ventricular outflow tract will lead to flow from left to right. This, as we know, will be a setup for altering antegrade flow in the aorta and decrease flow across the already vulnerable area of the aortic isthmus, and will be a setup for aortic arch hypoplasia and coarctation. A similar phenomenon occurs in the setting of tetralogy of Fallot, where we have malalignment anteriorly of the septum, which is going to cause crowding in the right ventricular outflow tract, and preferential flow across the VSD from the RV to the LV. Saturations are relatively preserved in this fetal circulation, and depending on the degree of decreased flow to the pulmonary arteries, we may see that pulmonary blood flow is actually supplied by a classic reverse-oriented ductus arteriosus. Important to note that the increase in flow across the systemic structures, across the aorta, may result in actually increase in the size and measurement of the aorta and the isthmus. And finally, in fetal circulation, with detransposition, intact ventricular septum, venous return patterns are unchanged, but importantly, the oxygen content of blood delivered to the tissues is significantly altered. So the coronaries and the central nervous system receive blood that is significantly desaturated. Interestingly, it's thought that there are changes in the fetal cerebral vascular resistance, a decrease in cerebral vascular resistance that serve to compensate for the decreased oxygen delivery in this circulation. Okay, so we are going to leave fetal circulation and move on to a discussion of the basics of cardiac structure and function. So starting with the cellular components of the heart. So the heart is comprised of many cell types. Our focus will be the structure and function of the myocytes, which comprise only about 30% of the total cellular components of the heart. Fibroblasts make up the majority of the cellular components. They provide structural integrity and have a significant role in remodeling and signaling in fibrosis. And the remaining components are going to be the conduction system and the vascular tissue. The myocytes have two major functions. The first is force generation by myofibrils in response to excitation-contraction coupling, which we will spend some time focusing on and reviewing this morning. And then force transmission across cell bundles as an organ as a whole, mediated by communication via the intercalated disc and extracellular membrane via costomeres. And within this myocyte, the critical structure to understand is the sarcomere, which is the fundamental contractile unit. And looking at the key components of the sarcomere, we'll start with the thick filament. The thick filament made up of myosin, which is the most abundant protein in the myocyte, comprises the A band in this diagram, and the thin filament actin with the troponin and tropomyosin complex, which interact in a calcium-dependent interaction. And the cycle of contraction and relaxation in the myocyte is modulated by changes in intracellular calcium, which is tightly controlled. And this is going to occur at two key locations. The first is the cell membrane, and the cell membrane is where the cardiac action potential is translated into important intracellular events. So at the cell membrane, under resting conditions, there are many pumps and channels that maintain the resting potential and ion concentration, specifically calcium. So when the myocyte depolarizes, the key protein that transmits the action potential and allows influx of extracellular calcium is the L-type calcium channels. These are a key player in calcium metabolism, specifically in neonatal hearts, where the sarcoplasmic reticulum is less mature, and the influx of extracellular calcium is really crucial to contractility. In terms of restoring intracellular calcium levels to relaxation and diastole, the protein to remember is the sodium-calcium exchanger. Obviously, the other critical site for calcium metabolism is the sarcoplasmic reticulum. This is the primary site of calcium storage during diastole and release during depolarization. And the key protein to remember on the sarcoplasmic reticulum are the ryanodine calcium release channels. These are going to release calcium from the SR in response to the calcium influx from the cell membrane. This is a nice summary diagram of the process. You have depolarization and calcium inflow from the cell membrane via the L-type calcium channels, right here. That activates ryanodine calcium release channels on the sarcoplasmic reticulum. This phenomenon is known as calcium-induced calcium release and is what is responsible for the sharp increase in intracellular calcium during systole. The increase in calcium then activates the contractile elements in the sarcomere, and contraction occurs. Proteins like SIRC-A2 on the SR and the sodium-calcium exchanger on the cell membrane work to restore the resting membrane potential and intracellular calcium levels during diastole. And this coupling of the cardiac action potential with increases in intracellular calcium released from the sarcoplasmic reticulum and then subsequent actin-myosin crossbridge formation is what we fondly refer to as excitation-contraction coupling. The excitation component we've discussed in detail, depolarization of the myocyte leading to release of calcium from the sarcoplasmic reticulum, and this brings us back to what's happening in the sarcomere. Calcium remains the key player in starting contraction at the level of the sarcomere. So it's actually binding of calcium to troponin C on the thin filament causes a conformational change, and the troponin complex is lifted away to uncover myosin binding site on the actin thin filament, and the myosin and actin crossbridge is allowed to form. The myosin heads attach, rotate, and generate force and move the actin filaments, similar to oars in the water. Myosin detaches from actin in what is an ATP-dependent process, and the cycle repeats, bringing the two Z lines of the sarcomere together until cytosolic calcium levels fall and diastole begins. Again, a summary of this process. The contractile cycle is going to begin with the influx of calcium, conformational change in troponin complex allowing crossbridge formation. And remember that the magnitude and duration of peak calcium is what's going to govern the strength of contraction. So a higher calcium concentration in the cell is going to lead to greater crossbridge formation and greater force that is generated. Once myosin latches, it flexes, moving the actin filament. The myosin head binds to and splits ATP, which allows it to release from actin, subsequently unflex and be available for the next crossbridge formation. And important to remember that the release of the actin and myosin crossbridge is an ATP-dependent process. So you can imagine there are many force factors that regulate excitation-contraction coupling. The peak regulator, or the primary regulator, is going to be the amplitude and duration of peak calcium in the myocyte, but also the sensitivity of the contractile proteins to calcium, which has developmental features. So there are developmental changes in the subtypes of troponin that are expressed. In addition, sympathetic activation will alter gene expression and in general serve to increase the sensitivity to calcium and increase the force of contraction, whereas states like acidosis tend to alter this process and have the opposite effect. One of the fundamental principles governing excitation-contraction coupling is the concept of the length-tension relationship. Simply put, this is the fact that longitudinal stretch of the myocyte is going to enable the myocyte to generate proportionally more force for a given concentration of calcium. This is the principle that is underlying the Frank-Starling relationship, where increasing preload leads to increased stroke volume. There are many proposed mechanisms that increasing the stretch of the sarcomere is going to optimize myofibril overlap, will increase the local concentration of myosin heads available for crossbridge formation, and also capitalizes on the elastic recoil properties of titin. We'll spend some more time talking about this. This relationship holds true under both resting tension as well as active tension, that the force generated is going to be increased by the state of stretch of the myofibrils. Another important modulator of excitation-contraction coupling and contractility is the sympathetic nervous system. Via activation of the cardiac beta adrenergic receptors, sympathetic input is going to affect many of the key proteins in excitation-contraction coupling. Through beta receptor activation and a G protein-mediated pathway, this is going to lead to increase in cyclic AMP and activation of phosphokinase, which is going to serve to phosphorylate and upregulate many of the proteins involved in excitation-contraction coupling, resulting in an increase in the amplitude and peak of serum calcium or intracellular calcium, and an increase in the force generation. Will also serve to upregulate gene expression of the key proteins involved. Thyroid hormone also plays an important role in supporting heart function via its effects on excitation-contraction coupling. It impacts the heart's ability to respond to sympathetic input and increases the expression of many key proteins. Thyroid hormone is also critical for mitochondrial production and ATP production. And thyroid hormones also play a key role in preparation of the fetal myocardium for transition to postnatal life. This is a nice brief reference to summarize some of the developmental features that impact excitation-contraction coupling. So specific things to know about that differentiate an immature heart is that there is a decrease in the total number of contractile elements. In addition, the sarcoplasmic reticulum is much less well developed in terms of its ability to store calcium, so the fetal and neonatal myocardium are much more dependent on extracellular calcium sources and influx of calcium from the cell membrane. In addition, direct sympathetic innervation to the neonatal myocardium is still developing, and so neonates and fetuses are much more dependent on the presence of circulating catecholamines. So we're going to spend some time talking about ventricular function and some of the determinants of cardiac output. And in considering the main determinants, of course, we think of these three critical components. The first is preload, so the stretch or length of the muscle prior to contraction. Again, the length-tension relationship that we've discussed. This is determined by the end diastolic volume in the ventricle, and clinically we use the end diastolic pressure to approximate this. Afterload, the force that the ventricular muscle is pumping against, which is going to include the peak arterial pressure as well as vessel compliance. And when we're looking at a vascular bed, the overall resistance of the vascular bed. And finally, contractility, which is going to be the intrinsic intensity of the force of muscle contraction that is independent of both preload and afterload. These concepts have been studied and described in the context of this model, which is a single papillary muscle. And the use of this model is really that you can adjust your levels of afterload and preload and measure the amount of force that is generated, separate the different conditions, and determine the force of contractility. Another clinically useful model for understanding ventricular function is the pressure volume loop, also something that I think is easily testable on the exam. It's really a graphic representation of how LV volume and pressure change over the cardiac cycle and under different conditions. And we're going to walk through the key features and relationships that can be examined as part of the LV pressure volume loop. So starting with diastolic filling, you have the mitral valve opening and the ventricle filling to end diastolic volume. Mitral valve closes in isovolumetric contraction. To the point where the aortic valve opens, you have ejection, rapid ejection, and then isovolumetric relaxation, and the cycle continues. Probably the most important component of the pressure volume loops to keep an eye on is going to be the stroke volume. And it allows you to look at stroke volume and compare it under different conditions of preload and afterload. It's also important to understand the curves that border the pressure-volume loop, specifically the end diastolic pressure-volume loop, end diastolic pressure-volume relationship. It's going to reflect ventricular diastolic function and ventricular compliance. You move along this curve as the LV fills, and the slope and shape of the curve changing as compliance changes. The end systolic pressure-volume relationship reflects two important features of cardiac function. So the slope of this line is going to reflect the contractile state of the heart. Increases in slope, so the slope moving up, is going to reflect increasing contractility and increasing stroke volume. Where the pressure-volume loop intersects the ESPVR curve is going to be your afterload. And on a given ESPVR line moving up or down, the curve is going to reflect changes in afterload. So looking at preload, we have a pressure-volume loop on the left and a corresponding Starling curve on the right. So again, revisiting the fundamental length-tension relationship in the Frank-Starling curve. Here we see how pressure-volume loop changes with increasing preload. So as preload increases, stroke volume is going to increase for a fixed contractility and afterload. This will continue until we've reached or exceeded the stretch of the myocardium, at which point end diastolic pressure is going to increase, and clinically this is when we're going to see congestion and backup of fluid in the form of pulmonary edema and pleural effusions. Important to remember that the Starling curve will change depending on both contractility, so increasing contractility will deliver an increased stroke volume for a given preload, and will also change based on afterload. So increasing afterload is going to decrease stroke volume for a given preload. Okay, so shifting our focus to the end diastolic pressure-volume relationship and ventricular compliance. A non-compliant stiff heart will demonstrate poorer diastolic function, so higher diastolic pressures and lower stroke volume for a given preload. This could be due to hypertrophy, ischemia, cardiopulmonary bypass. So for example, shifting the diastolic compliance curve from B to A, moving leftwards, represents worsening diastolic function, impaired filling at the expense of higher pressures. Whereas moving rightward and down on your end diastolic pressure volume curve, for example, if you started a lusitropic agent such as milrinone, represents improving diastolic function and improved compliance of the ventricle. Finally, when interpreting these curves, remember that changes in afterload are represented by moving up and down along a given ESPVR curve. So higher afterload will translate into lower stroke volume for the same preload. Whereas changes in contractility are actually changes in the slope of the line. So as we see clinically, increasing contractility, increasing the slope, will yield a larger stroke volume for a given preload. So when you're on the exam working your way through pressure-volume loops and different disease states, really take a step back and look at the different components. Look at the stroke volume, which is going to be represented by the width of the curve. Look at the peak ventricular pressure, which is going to be this axis. And look at the end diastolic volume, where the curve actually occurs here on LV volume. So when looking through this, which disease state causes a really huge, has a really high end diastolic volume and a very small stroke volume, that's going to be a big dilated cardiomyopathy. Which disease state is going to result in a really substantial increase in LV peak pressure? That's going to be a heart that has increased afterload from aortic stenosis. Looking at a disease state that's going to cause both pressure and volume increase, that's going to be mixed aortic valve disease, so aortic stenosis and insufficiency. And then looking at a heart that's going to have increased end diastolic volume but decreased ventricular pressure, something that's sort of decompressing the ventricle during systole, that's going to be a heart with mitral regurgitation. All right, so we're going to finish off with a review of some key concepts with regard to vascular physiology. Starting with the pulmonary vascular bed, and then looking at some of the unique features of the different vascular beds in the systemic circulation. Common to all vascular physiology, we have to mention the fundamental concepts of Ohm's law, the basis of our hemodynamic calculations in the cath lab. It's also important to recognize the factors that impact resistance to flow through a vessel or a vascular bed. Vessel length plays a role in this, but by the Poisson relationship, it's actually vessel radius that's the most significant contributor to overall vessel resistance. And when we look at a whole vascular bed, it's not just the radius of the individual blood vessels, but the total cross-sectional area of the vascular bed. Two important components to every blood vessel in the body: the vascular smooth muscle, which is going to constrict via calcium-mediated excitation-contraction coupling, and the vascular endothelium, which has many, many roles in regulating vascular tone. Important to remember that while there are many mechanisms underlying vascular physiology, the goal is always to maintain adequate oxygen delivery to the target organ or tissue under a wide array of physiologic states. The mechanisms are complex, and they're going to vary by organ to organ and different vascular beds, but important to remember this underlying principle. So we're going to start with the pulmonary vascular bed. Pulmonary circulation is unique in many ways. It's normally a low pressure, low resistance system that conducts an entire cardiac output. The pulmonary bed demonstrates exquisite sensitivity to oxygen. So oxygen is a potent vasodilator in the pulmonary vascular bed, as is a higher pH and nitric oxide, either exogenous or produced by the pulmonary vascular endothelium. Hypoxia, conversely, is a potent vasoconstrictor in the lungs, as is acidosis and other mediators that the vascular endothelium produces, such as histamine and endothelin. Also important to note that the lung is unique in that the mechanical state of the lung is going to affect overall pulmonary vascular resistance. So states of atelectasis and also states of overexpansion or overdistension are going to compress different components of the pulmonary capillary bed and are going to lead to increased resistance. So we see this in the ICU very frequently. Both pulmonary vascular resistance and lung function are going to be optimal at the functional residual capacity of the lung. We've previously mentioned some of the transitions in the pulmonary vascular bed at birth, where physical expansion of the lungs and increased oxygen delivery to the pulmonary bed result in an abrupt decrease in pulmonary vascular resistance. And the pulmonary vascular endothelium plays a significant role in producing and responding to many of the key mediators, such as nitric oxide, endothelin, and prostaglandin. Nitric oxide and the prostaglandins functioning to cause vasodilation, whereas endothelin is a potent vasoconstrictor. And as you will discuss later this week, many of these pathways are therapeutic targets in the field of pulmonary hypertension. Now turning our attention to the systemic vasculature. So recognizing that there are many mechanisms in place that serve to control blood flow and help regulate and control flow to competing vascular beds under a variety of conditions and blood pressures. The primary goal is always to maintain adequate oxygen delivery to the tissues, regardless of the physiologic state. And the primary mechanism that governs this is autoregulation. So transient local alterations in blood flow to maintain adequate oxygen delivery despite a changing blood pressure. This is a pretty complex phenomenon, and the mechanism is not perfectly understood. It's thought to be related to vascular tone changes in response to tissue oxygen delivery. And different vascular beds are going to demonstrate different degrees of autoregulation. Organs like the brain are able to maintain very constant blood flow and oxygen delivery over a wide range of pressures. This is considered very tight autoregulation. In contrast, the splanchnic and cutaneous vascular beds show very minimal ability to autoregulate, with blood flow to those vascular beds changing dramatically as changes in perfusion pressure occur. Important to recognize that the autonomic nervous system plays a key role in regulating systemic vascular tone, both at rest and under stress. So input from both baroreceptors and chemoreceptors via afferent input to the brainstem play a key role in this process. So we'll review these briefly. The baroreceptors are located in the carotid sinus and the aortic arch. The type 1 baroreceptors govern dynamic changes in blood pressure, while the type 2 baroreceptors control blood pressure under resting conditions. Increased arterial pressure is going to lead to increased firing of the baroreceptors, and this leads to an inhibitory action on the sympathetic nervous system and an increase in vagal tone and parasympathetic output. Conversely, in the setting of hypotension, the opposite is true. There is decrease in baroreceptor firing. This disinhibits the sympathetic response and downregulates the parasympathetic response. So increasing your sympathetic drive, leading to increase in systemic vascular resistance and increase in blood pressure. The chemoreceptors, also located in the aortic arch and the carotid body, but also elsewhere in your brain, your coronary arteries, primarily play a role in responding to dire situations, specifically hypoxemia and hypercarbia. And they lead to the protective response of increasing SVR and increasing respiratory drive. Again, with afferent input to the brainstem and efferent output via the sympathetic nervous system. In terms of circulating factors that impact systemic vascular resistance, the two key groups are the circulating catecholamines. Released from the adrenal medulla, they act via the adrenergic receptors on the vasculature and the myocardium, as well as the production of angiotensin II in the kidney, which is produced in response to decreased renal perfusion. It serves to cause both of these serve to cause increased vascular tone, and in the case of angiotensin, increased production of antidiuretic hormone and water retention. So we'll finish with a brief review of two specific systemic vascular beds, the cerebral and the coronary circulations, are both unique and I think important to know for the exam. So the brain is unique in many ways. It relies entirely on glucose metabolism and has no intrinsic energy stores. And as we know clinically, the brain does not tolerate decreased perfusion. So the brain requires a fairly constant, steady flow within a very fixed range to maintain its metabolism. So the brain exhibits very tight autoregulation, where it's able to alter vascular tone to maintain a steady blood flow across a wide range of blood pressures. The brain also demonstrates unique and protective response to hypercarbia and hypoxia. Hypoxia, specifically PaO2s less than 50, causes a dramatic decrease in cerebral vascular resistance and compensatory increase in flow. The brain also responds to respiratory acidosis, but because of the blood-brain barrier, it's actually mediated by carbon dioxide and not just pH. So it's respiratory acidosis and not metabolic acidosis that lead to an increase in cerebral blood flow. And finally, the coronary circulation, a few key points. The heart has, at baseline, a very high degree of oxygen extraction. So the heart cannot extract more oxygen to meet increased metabolic demands. It has to increase coronary blood flow. And the increased flow needs to occur regardless of the coronary perfusion pressure. So if coronary perfusion pressure does not change, flow must be increased by decrease in coronary vascular resistance, phenomenon known as metabolic regulation. So with metabolic regulation, it's important to understand the concept of coronary flow reserve, which is the degree to which the heart can increase effective coronary blood flow under normal conditions. So under normal conditions, cardiac metabolism and coronary blood flow are coupled, and coronary blood flow is autoregulated to preserve flow within a given range despite changes in perfusion pressure. Outside a given perfusion pressure, flow can be increased by maximal dilation of the coronary arteries. There are many disease states that can affect this maximal flow reserve, such as tachycardia, decreasing your time in diastole, anemia, ventricular hypertrophy, acute ventricular dilation. So some key disease states to know about. And with that, I will finish our tour of basic physiology.
So number one, the following, the statement that best describes fetal myocardial function is A, the fetal myocardium is able to maintain a relatively stable cardiac output over a wide range of heart rates. B, the fetal myocardium demonstrates the ability to preserve stroke volume despite increased afterload. C, the fetal myocardium has fewer contractile elements, and the sarcoplasmic reticulum is immature with less robust calcium stores. D, the fetal myocardium has robust preload reserve, and it's able to augment stroke volume effectively with increases in preload. And E, the fetal myocardium has increased number of adrenergic receptors and mature direct sympathetic innervation. So choose your answer. Excellent. So the majority of you got this right, which is that the fetal myocardium has fewer contractile elements and actually a little more water content than the adult myocardium, and the sarcoplasmic reticulum is immature and less robust calcium stores. This is the reason why some people feel that calcium could be an inotrope in neonates. So the preferred answer is C. A, in the fetus, the ability to modify stroke volume is limited. As such, changes in the heart rate serve as one of the primary determinants of fetal cardiac output. A decrease in fetal heart rate is not accompanied with compensatory increase in stroke volume, and as such leads to decreasing total cardiac output, not an increase. Option B is incorrect because the fetal myocardium is very sensitive to afterload, and the stroke volume achieved for a given preload decreases rapidly with increasing afterload. Option C is correct because there are fewer total number of contractile elements in the fetal myocardium, and the sarcoplasmic reticulum and T-tubule systems are poorly developed. The fetal myocardium is more dependent on influx of extracellular calcium via the L-type calcium channels, as the ryanodine receptor function on the sarcoplasmic reticulum is not yet fully developed, which is the reason why that answer was correct. And D was incorrect because the fetal myocardium is relatively less compliant and has limited preload reserve, operating at a peak plateau of its ventricular function curve. And E was incorrect because the fetal myocardium has decreased number of adrenergic receptors, and direct sympathetic intervention is not completely developed until after birth. This is a relatively straightforward question in which only one of the choices is correct and the other ones are not. The board is likely to put choices in front of you that many of them may be correct, but may not be the best answer, so watch out for that. So we'll do the next question. Of the following, the statement that best describes the circulation through the right ventricle in the fetus is A, the majority of venous inflow to the right ventricle is comprised of highly saturated blood coming from the inferior vena cava and ductus venosus. B, the right ventricle is responsible for approximately 60% of combined ventricular output in the fetus, with the majority of the flow from the right ventricle crossing the ductus arteriosus to the descending aorta. C, the oxygen content of blood traversing the right ventricle of a fetus with detransposition of the great arteries, the TGA, is considerably lower than in the fetus with normally related great vessels. Option D, right ventricular afterload increases dramatically immediately following birth compared to fetal circulation. And option E, the oxygen content of blood traversing the right ventricle of a fetus with mitral and aortic atresia of the hypoplastic left heart syndrome child is considerably lower than in a fetus with normal cardiac anatomy. Choose your answer. Anybody in? And most of you were correct. but a little bit, there's a small portion of you who actually thought that the majority of the venous inflow to the right ventricle was comprised of highly saturated blood coming from inferior vena cava and ductus venosus. I will talk about that in a second, but so the right ventricle is responsible for approximately 60% of combined ventricular output in the fetus, with the majority of the flow from the right ventricle crossing the ductus arteriosus to the descending aorta. The reason why option B is correct, because in fetal circulation, the right ventricle is dominant, and approximately 2/3 of the flow from the right ventricle traverses the ductus arteriosus to the descending aorta. Option A was incorrect, because the majority of the tricuspid valve inflow is comprised of highly desaturated blood from the superior vena cava. Approximately 90% of the SVC flow crosses the tricuspid valve, and this combines with a portion IVC flow that is not directed across the foramen ovale to the left atrium. Option C was incorrect, because the venous inflow of the right ventricle is normal in detransposition, and as such, the desaturation of blood in the RV is typical 55%. However, in detransposition, this is the blood that is delivered to the coronary and cerebral circulations, like Amy mentioned, which is considerably lowered than in a fetus with normally related great vessels. Option D was incorrect, because immediately after following birth, there's a dramatic decline in pulmonary vascular resistance and increase in pulmonary blood flow due to the mechanical expansion of the lung parenchyma, increase in oxygen content, and decrease in PCO2. These changes serve to decrease right ventricular afterload in the neonate as compared to the fetus. And option E was incorrect, because the single right ventricle in the fetus with hypoplastic left heart syndrome receives all the venous inflow, including the more highly saturated flow from the IVC and ductus venosus that would normally cross the PFO into the left atrium, and as such, the saturation of blood into the RV in this setting is higher than in the normal fetus, up to 60%. Question 3. Of the following, the mechanism that best describes the function of the L-type calcium channels in excitation contraction coupling is option A, voltage-gated channels located on the cell membrane that allow influx of extracellular calcium in response to the myocyte depolarization. These proteins contribute to the plateau phase of the cardiac action potential. Option B, channels located on the sarcoplasmic reticulum, which respond to an increase in intracellular calcium by allowing calcium to be released from the sarcoplasmic reticulum, known as calcium-induced calcium release. This release of calcium from the sarcoplasmic reticulum triggers the contraction phase of excitation contraction coupling. Option C, these proteins function to pump calcium back into the sarcoplasmic reticulum, restoring intracellular diastolic calcium concentrations during diastole and terminating calcium-dependent force activation. Option D, this protein binds to calcium, causing a conformational change, which uncovers the ATP reactive site and allows the actin and myosin cross bridge to form. And option E, this protein is located on the plasma membrane that utilizes the sodium electrochemical gradient to extrude calcium out of the cell in exchange for sodium, helping to maintain intracellular calcium levels during diastole. So the question here is, what of the following the mechanism that best describes the function of the L-type calcium channels is? Please choose your answer. They're long answers, but I think they will help you knowing why the answer would be correct when you see it in a short version in a test. Oh, interesting. So option A was correct. The majority of you thought actually that was correct. The voltage-gated channels located in the cell membrane that allow influx to the extracellular calcium in response to the myocyte depolarization. And these proteins contribute to the plateau phase of cardiac action potential. Many of you thought the B actually was the correct answer. Let's look at it. Option A, these channels play an important role in excitation contraction coupling in the fetal and neonatal myocardium in the setting of the immature sarcoplasmic reticulum and reduced intracellular calcium stores. Option B, this describes the function of the ryanidine calcium release channels. Option C, that describes the function of the cardiac sarcoplasmic reticulum calcium channel ATPase through circa 2A. And option D describes a function of troponin C. And option E describes a function of the sodium-calcium exchanger that keeps the calcium gradient in check. Any comments, Amy?
Basically just that the L-type calcium channels are going to be on the cell membrane. The ryanodine receptors are on the sarcoplasmic reticulum. That's the important distinction to remember.
Can you also maybe comment on the importance of L-type calcium channels and calcium channel blockers used in infancy?
Right. So the concern there is that with blockage of the cell membrane receptor calcium channels, that in the myocardiums that are more reliant on extracellular calcium influx for contractility, that a calcium channel blocker may impair that and may reduce contractility. So that's specific in neonates and in younger infants who have a less well-developed sarcoplasmic reticulum.
Specifically about the use of probably verapamil, or the absence of its use in neonates, as the contractility is believed to be more calcium dependent, and the calcium is just less available.
What's the difference between the ryanodine and the circa calcium channels?
Yes.
Yeah. The ryanodine receptor is on the sarcoplasmic reticulum, and it's going to respond. So you have depolarization of the myocyte and calcium influx through the L-type calcium channels. That increase in calcium is going to activate the ryanodine protein on the sarcoplasmic reticulum and allow release of calcium from the sarcoplasmic reticulum during systole. The circa 2A protein is going to be what restores intracellular calcium levels to diastolic levels during relaxation. So,
Which requires ATP, right?
It does, yes.
So a lovely pressure volume loop. A 6-month-old male is recovering in intensive care following an uncomplicated surgical repair of a large paramembranous ventricular septal defect. He has a heart rate of 160 beats per minute, central venous pressure is 11, and the systolic blood pressure is 64/40 millimeters of mercury. He started on milrinone infusion to support his hemodynamics. Of the following, the mechanism that best explains the effects of milrinone on the pressure volume curve is, right below is the pressure volume curve, showing the end diastolic pressure volume relationship and the end systolic pressure volume relationship. And the stroke volume is the zone marked inside the loop. A, milrinone will increase LV compliance, shifting the end diastolic pressure volume relationship curve up and to the left. B, milrinone will cause increased LV contractility, decreasing the slope of the end systolic pressure volume relationship curve, and as well as decrease afterload on the LV, moving upward on a given end systolic pressure volume relationship curve. C, milrinone has no inotropic effect and will not alter end systolic pressure volume relationship slope. The primary effect will be to decrease LV afterload, which will result in moving upward along the end systolic pressure volume relationship line. D, milrinone will increase LV contractility, which results in increasing the slope of the end systolic pressure volume relationship curve, decrease afterload on the LV, which results in moving downward on the end systolic pressure relationship curve, and decrease LV compliance, which results in shifting the end diastolic pressure volume relationship curve down and to the right. And E, decreased LV compliance will be caused by using milrinone shifting the end diastolic pressure volume relationship curve down and to the right. So what does milrinone do to your pressure volume loop? That's actually a possible choice. Please choose your answer. It is likely also to show up as a question of what inotropes will do to your end systolic pressure volume relationship, period. What does it do to the slope? Okay, so 90% of you thought that milrinone actually will increase LV contractility, which is good, because given that it's an inotrope, that's a good thing. In increasing the slope on the end systolic pressure volume relationship curve and decrease afterload, which results in moving downward on the end-systolic pressure relationship curve and increase the LV compliance, which results in shifting in a diastolic pressure volume relationship. Interestingly, a lot of the diastolic properties that have been attributed to milrinone are hard to measure. Even doing echoes, the properties that have been attributed to milrinone are hard to measure. Even doing echoes after you start individuals on milrinone doesn't show a lot of changes in contractility. But there's lab evidence that has shown that in animals, and a lot of the effects that milrinone produces in cardiac index are mostly peripheral. They're not specifically only related to the myocardium.
So it has inotropy, losiotropy, which is the improving compliance, and then afterload reduction. So those three mechanisms you should keep in mind.
So we're going to discuss now a few things. I think this is one of the questions where the critique is as valuable as getting to the question. So why is answer A wrong? Milrinone does have a positive impact on LV compliance and diastolic function, a property known as lusotropy, as Shaji mentioned. Improving compliance, however, will shift the end-diastolic pressure volume relationship curve down and to the right. It will make it easier for the ventricle to accommodate more volume at lower pressure. That's the property of compliance, equating to a larger stroke volume for a given LA pressure. And B, milrinone does have a positive inotropic effect, but positive inotropy will increase the slope of the end-systolic pressure volume relationship curve. Milrinone also causes both systemic and pulmonary vasodilatation and a decrease in afterload. For a given inotropic state, a decrease in afterload represents moving downward along the end-systolic pressure relationship slope. And Amy, do you want to make a comment on that? Because I think that's important.
Yeah, I think that the key for the end systolic pressure volume curve is that contractility is going to change the slope, and changing afterload, you're going to move up and down a given curve. So increasing the slope is going to increase your stroke volume, whereas going up on the curve is going to shrink your loop. So increasing afterload is going to decrease stroke volume for a given preload.
Questions?
You will get a question on pressure volume loop. So make sure you understand what is the diastolic component, which is the lower line, and the systolic component, which is the upper line. So increase the cardiac output, the upper line has to become more vertical, and the lower line has to become more flatter, so the box expands. Does that make sense? So if you are not going through the rigor of understanding this model, at least keep that in mind. But it is important for you to understand the whole model to really put it together. But this is something that you should spend your time on understanding.
So the area inside the loop is the volume moved by every beat.
Yeah. Right.
And as you move more volume, the slope that is this is diastole, this is isovolumic contraction, this is rapid ejection phase, and here it's when, it's what by pressure volume loops is how you measure contractility. So the way to sort of think of this is that inotropes will change your slope because you have a larger amount of cardiac output being pushed at every beat, and that will be represented by the slope actually being inclined further.
You mentioned that you want to make the box bigger, so then if you move down along that curve to make the box smaller.
It might help to show this slide.
No.
Yes.
So this is just kind of a summary of milrinone. So the little black loop is your baseline. And with milrinone, you're going to have increased compliance. So you're going to move your end diastolic volume slope down and to the right. You're going to have increased inotropy, so the end systolic pressure volume curve, the slope changes, it increases, and then also decreased afterload. So for that given curve, you're probably going to move down a little bit, and the net effect is that you're going to have increased stroke volume. But you've changed the compliance of the heart, you've changed the contractile state and the afterload.
So if you may want to add, how is this different from epinephrine?
Yeah, that's a good point.
So because epinephrine will have no effect on, and that's the pressure-volume relationship, but will have an effect on only systole.
Yeah.
So the box will grow not more laterally, but just up.
Yeah.
And milrinone is a type 3 phosphodiesterase inhibitor, which blocks a breakdown of cyclic AMP, leading to an increased intracellular calcium and increased myocardial contractility. This will increase the slope, or make the slope steeper, I guess. I'm saying that right? Increase the slope of the end-systolic pressure-volume relationship curve. Milrinone also acts to improve ventricular compliance, decreasing diastolic filling pressures, which will shift the diastolic pressure-volume relationship curve down and to the right. Finally, milrinone also causes both systemic and pulmonary vascular smooth muscle relaxation, which will decrease afterload of the left ventricle. So I think that there's a difference between thinking of inotropes like catecholamines and thinking of milrinone. Milrinone has a specific effect on both contractility and systolic and diastolic pressure-volume relationship, like the curves show. So, and most of you got that answer correct. Question number 5. A 5-month-old female is recovering in intensive care unit following uncomplicated repair of tetralogy of Fallot. She has a heart rate of 170 beats per minute, central venous pressure of 4 millimeters of mercury, and a blood pressure of 59/34 millimeters of mercury. She receives a fluid bolus of 20 mL per kilo of normal saline. The mechanism that best explains the effect or effects of the fluid bolus on her myocardial function is, or are, A, the fluid bolus will result in longitudinal stretch of the myocardial muscle fibers, which will decrease the amount of force of the myocardium the myocardium is able to generate. Option B, the fluid bolus will acutely increase systemic blood pressure, resulting in increased ventricular afterload and decreased left ventricular stroke volume. Option C, the fluid bolus will increase left ventricular and diastolic pressure and volume, leading to increase in stretch of the myocardial muscle fibers and resulting in increased contractility and increased left ventricular stroke volume. Option D, the fluid bolus will give a less effect on cardiac output if the patient is started on dopamine infusion to increase inotropy. E, the fluid bolus will have a greater effect on cardiac output if the patient was started on norepinephrine to increase systemic vascular resistance and ventricular afterload. So what best explains the effects of a fluid bolus on this patient is, or are. Had to put that in there. Great. So the majority of you thought that the fluid bolus will increase the left ventricular and diastolic pressure and volume, leading to an increase in stretch or recruitment, if you will, of the myocardial muscle fibers, a principle that Amy explained also in association with the Starling principle. And that will lead to increased contractility and increased left ventricular stroke volume. Thought that was pretty straightforward. Amy, comments?
No.
So, and why A and B are incorrect. A is by the principle of length tension relationship, increasing preload and longitudinal stretch of the myofibrils results in an increase of force generated. That is thought to be due to the optimization of myofilament lattice spacing, which enhances actin and myosin cross-bridging formation. A fluid bolus will increase ventricular preload, and by the Frank-Starling relationship, this will increase stroke volume and likely increase overall cardiac output, while this way have downstream effect on blood pressure. Fluid bolus in this setting will not accurately change afterload. So by the principle of length-tension relationship, increasing preload and longitudinal stretch of the myocyte results in increase in force generated. This is exactly how it was explained earlier, and most of you got this question correct. Why dopamine or norepinephrine are incorrect. Dopamine will provide increased inotropy and will result in greater stroke volume for a given preload. Changes in LV/AVP or LV and diastolic volume by enhancing contractility with dopamine. The fluid bolus would have a greater impact on cardiac output than without. And E, with increasing afterload, cardiac output normally will decrease for a given preload, particularly in the immature myocardium. As such, a fluid bolus would have less impact on increasing cardiac output if the patient was started on infusion that increased SVR and ventricular afterload. Question number 6. A day-old term infant born with obstructive total anomalous pulmonary venous return is in the intensive care unit 12 hours following surgical repair. Her current vital signs and hemodynamic monitors reveal the following. Heart rate is 183 beats per minute, CVP is 14, systemic blood pressures are 58 over 37 millimeters of mercury, oxygen saturation is 93%. A pulmonary artery catheter is placed and reveals a pulmonary arterial pressure of 50 over 32. An arterial blood gas was obtained with a patient receiving 100% oxygen and reveals a pH of 7.32, PCO2 of 49, PaO2 of 67, and a base deficit of -4. Which of the following interventions is most likely to reduce pulmonary vascular resistance in this patient? Option A, increase the PEEP on the ventilator to 10 in order to improve oxygenation and increase lung volumes to achieve relative lung hyperexpansion. B, employ a lung protective ventilator strategy and decrease the ventilator rate to maintain a goal of PCO2 of 55. Option C, administer an intravenous dose of sodium bicarb to buffer the base deficit and target a pH greater than 7.45. D, decrease the inspired FiO2 to avoid lung injury due to oxygen toxicity. And option E, decrease the sedation and analgesia infusions to allow for the patient to be more awake. So which of the following interventions on this patient with high pulmonary pressures is most likely to reduce PVR? Please choose your answer. So totally clear. And 16% of you thought it was increasing PEEP. 28% of you thought that using a lung protective strategy and decrease the ventilator rate to maintain a PCO2 that was a little bit higher. And several of you, the majority of you, thought that administering a dose of bicarb would be the best way to reduce PVR, trying to change the pH. Maybe one of you thought that decreasing the FiO2 would be helpful. This is the correct answer in C, and the aim of this question is to ask you, what is the PVR sensitive to? Is it sensitive more to changes in oxygen? Is it sensitive more to changes in CO2? Or is it more sensitive to changes in pH? That's what this question is asking. And the answers are, the correct answer is C, and I'll read that one first. That PVR will decrease in response to increasing the pH. This can be achieved either through increasing ventilation and decreasing CO2 or following correction or buffering of the metabolic acidosis as would occur with administration of sodium bicarb. If the patient had, for instance, a lactate of 5, using bicarb would not have been the correct answer. But in this patient in which lactate is not offered and the acidosis is deemed to be a combination of a metabolic state and some respiratory component, giving bicarbonate will be a reasonable choice. Amy?
Yeah, I think that the keys here are, what are your modulators of pulmonary vascular resistance? So pH and PCO2 are certainly key players. So changing ventilation to decrease CO2, bicarb in this scenario to increase your pH. The other ones are a little bit tricky. So oxygen's definitely a direct pulmonary vasodilator, and in this setting, to lower PVR, you want to keep your FiO2 at the highest that you possibly can. And you may even be reaching for other pulmonary vasodilators like nitric oxide. Option A is a little tricky. The point of that option was that you'd be targeting overexpansion of the lung. So keeping in mind that PVR is also going to be dependent on the mechanical state of the lung. So if you have lungs that are overexpanded on too much PEEP, that's actually going to work against you and increase PVR.
Yeah, so remember there's a little bit of an exponential relationship between lung volume and PVR. Overexpanded lungs will have higher PVR, underexpanded lungs will have higher PVR, and the point of lowest pulmonary vascular resistance is functional residual capacity, FRC, which is possible that may come up as a curve or as a question. Great. Of the following, the statement that best describes the function of regulation of cerebral blood flow is A, cerebral blood flow is tightly autoregulated to maintain consistent amount of flow and oxygen delivery over a broad range of systemic blood pressures. B, hyperventilation and elevation in CO2 leads to cerebral vasoconstriction. C, pH has a greater impact on cerebral vascular tone than CO2. D, hypoxemia results in increased cerebral vascular resistance. And E, the amount of cerebral blood flow correlates directly to systemic blood pressure under all conditions. Of the following, the statement that best describes the function of regulation of cerebral blood flow is. Please choose your answer. Good. So the majority of you, actually almost a good portion of the audience thought that the brain has the ability to control how blood flow goes in at a variety of pressures. Only a few vascular beds can do that. But the difference is that the brain controls resistance in the opposite fashion that the lungs control resistance, and hence the different choices that are there. So let's get to the choices, and the preferred answer is A, that cerebral blood flow exhibits tight autoregulation across a broad range of cerebral perfusion pressures to maintain constant oxygen and glucose delivery. Hypoventilation, which is option B, and increased CO2 leads to cerebral vasodilatation, which tends to be helpful when you're managing Glenn patients who are blue. Option C, as CO2 readily crosses the blood-brain barrier, elevations in PCO2 have a greater impact on cerebral vascular tone than pH. Metabolic acidosis does not alter cerebral vascular resistance, while respiratory acidosis has a significant impact. And option D, hypoxemia leads to cerebral vasodilatation and decreased cerebral vascular resistance. And option E, cerebral blood flow is actually tightly autoregulated. But there's a point in which this property of autoregulation is lost. Usually when there is profound hypotension, then you get to have a parallel relationship between the blood pressure and cerebral blood flow, which is option E.